shall discuss few of the important topics of antitubercular drugs. I shall discuss mostly the topic parts which is relevant to the examination. So you all know that tuberculosis, India has the highest tuberculosis burden in the world, and 2.2 million unique cases per year as per the latest data, as compared to the 9.6 million globally. So almost 2 out of every 9 patients of tuberculosis are from India, and 600 people in India die from tuberculosis every day. RNTCP, that is the Revised National Tuberculosis Control Program, was launched in 1997, and his treatment guidelines have been revised many times, last in 2019, and success rate was very good, 85% since 2005. And as it's due to its success, the name of the RNTCP has been now changed. Government is trying to eliminate the tuberculosis. Elimination means prevalence less than 1 per 10,000 population. So now the national program, we call it a National Tuberculosis Elimination Program, NTEP. So RNTCP is now called NTEP. So classification of the drugs, that is very important for your exam purpose. So if you look back into history, streptomycin, it was introduced in our year of independence, that is 1947, as the first antitubercular drug. And though its use has been now decreased, because streptomycin was an useful drug, but it needs daily injection for its tuberculosis control. So now we have few first line drugs and few second line drugs. So how to determine whether it is first line or second line? So first line drugs have high efficacy, low toxicity, and it is cheaper. And we have 5 first line drugs: isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin. Streptomycin is the only injectable. Rest 4 drugs, that is isoniazid, rifampicin, pyrazinamide, and ethambutol, these are 4 oral first line agents. And second line ATD, we have to use in some cases where organism, that is the Mycobacterium tuberculosis, is resistant to the first line drugs. Then we have to rely on second line agents, because second line agents, they have low efficacy, high toxicity, and costly. So they are not used as first line. When first line agents are not successful in achieving the tuberculosis eradication, then we have to use second line drugs. Second line drugs have low efficacy, high toxicity, costly. There are a number of second line drugs, and list is increasing day by day. So as per this common knowledge, we have enlisted few second line drugs: ethionamide, prothionamide, cycloserine, PAS, that is the para-aminosalicylic acid, rifabutin, thiacetazone, few fluoroquinolones like moxifloxacin, levofloxacin, aminoglycosides like kanamycin, amikacin, and clofazimine. These are the second line drugs. So if you are asked classification of the drug, you have to answer like this: first line drug and second line drugs. These are the site of action of different drugs. I shall discuss it later. So let's discuss one by one. Isoniazid, that is the tuberculocidal drug, and it is essential component of all antitubercular regime unless bacteria is resistant. Isoniazid is, in short, it is written as H, isonicotinonic acid hydrazide. That is the full form of INH, or in short we call it H. And fast transcriptable bacteria are rapidly killed, and they act on the extracellular and intracellular bacteria. And most non-tubercular mycobacteria are not inhibited. So there are, if you remember the microbiology, there are multiple non-tubercular mycobacteria also, but isoniazid acts exclusively on the Mycobacterium tuberculosis. Now, mechanism of action. Isoniazid enters the bacilli by passive diffusion, and it is activated to its toxic form within the bacillus by an enzyme that is called CATG. It is a catalase peroxidase enzyme, and this CATG catalyzes the production of this reactive radical that is called isonicotinyl radical, and it interacts with microbacterial NAD and NADP, and they form some adducts. So what is the net effect? So this nicotinyl NAD isomer that inhibits the activities of enoyl acyl carrier protein reductase and ketoacyl acyl carrier protein synthesis. So need not remember full name of this enzyme, but remember this INHA Cas A. So CATG, that is an enzyme present in the bacillus that converts INH into a radical, isonicotinyl radical. It is combined to NAD or NADP, and then Nicotinamide NAD isomer inhibits the activities of acyl acyl carrier proteins reductase, that is INHA and Cas-A. And net result is, due to inhibition of this INHA and Cas-A, there is inhibition of the synthesis of the mycolic acid, that is an integral part of the mycobacterial cell membrane. Thus, it interferes with the nucleic acid, also it interferes with the nucleic acid synthesis. So, it inhibits the synthesis of the mycolic acid, that is the key step by which INH causes cell tuberculocidal activity. And other products of catalytic activation of the INH are superoxide, hydrogen peroxide, alkyl hydroperoxides, and nitric oxide radical. Pharmacokinetics, one part you need to remember that isoniazid is metabolized by the hepatic N-acetyl transferase 2, and the metabolite is called N-acetyl isoniazid. So, this enzyme is important, NAT2. This NAT2, that is 75 to 95% excreted in the urine within 24 hours, and mostly as acetyl isoniazid and acetylcholine acid. Now, regarding the NAT2, depending on the NAT2 activity, patients has been traditionally classified as one of the two phenotypic groups, slow and fast acylator. So, patients in whom NAT activity is slow, we call them slow acylator, and in whom NAT activity is fast, we call it NAT2 fast acylator. So, slow acylator means INH will persist in the body for longer time, and there is chance of more adverse effects. So, slow acylator may be a greater risk of adverse effects from INH. And what are the common adverse effects? Peripheral neuropathy and hepatitis. And fast acylator have diminished response. So, fast acylator means INH will be metabolized rapidly, and that's why there can be chance of decreased response to standard dose of INH. But sometimes also fast acylator have some adverse effects, that because there is greater risk of activation by NAT2 of arylamine hydrazine carcinogen. So, fast acylator have this risk. Because of this NAT2 overactivation, there can be generation of this arylamine hydrazine carcinogen. And mostly Indians are slow acylator, 70% Indians slow acylator, in fast acylator present in US and Japanese. Okay. So, remember this pharmacokinetics, this is actually an example of pharmacogenetics. So, INH acetylation status, depending on the slow and fast accelerator status, patients are divided into slow and fast accelerator. Slow accelerators are at risk of more adverse effects like hepatitis and neuropathy, and fast accelerators have risk of decreased response, and also there is chance of development of carcinogens. Adverse effects: hepatitis manifested by the increased AST and ALT, and severe injury is rare, like 0.1%. Peripheral neuropathy is much more common, and this is more frequent in the slow accelerator and in individual with diabetes, poor nutrition, and anemia. And to prevent this neuropathy, we have to use pyridoxine along with INH, and pyridoxine should be continued as long as INH is continued. And in higher dose, rarely there can be mental abnormalities including euphoria, transient impairment of the memory, and loss of self-control psychosis. So, INH inhibits pyridoxine phosphokinase, and this is necessary for the activation of the pyridoxine to pyridoxal 5-phosphate. That is a cofactor for many important reactions, and this deficiency of the pyridoxal phosphate due to this INH, this is the reason for the neuropathy due to INH. So, INH administration means we have to use pyridoxine from the outside, so that there is adequate supply of generation of the pyridoxal 5-phosphate. There can be hypersensitivity, vascularitis, and associated with antinuclear antibodies. So, drug-induced SLE, one example is isoniazid. There can be shoulder hand syndrome, arthritis. Isoniazid overdose has been associated with clinical triad of seizures, which can be refractory to different antiepileptic. It can cause refractory metabolic acidosis, and rarely it can cause coma. And drug interaction, it is a potent inhibitor of the cytochrome enzyme like CYP2C19 and 3A, and it's a weak inhibitor of the CYP2D6. However, isoniazid also induces CYP2E1. So, drugs that are metabolized by this enzyme will be potentially affected, like paracetamol, so phenytoin, carbamazepine, warfarin, diazepam, and theophylline. So, isoniazid induces CYP2E1, and this is a 2E1 enzyme actually responsible for the toxic metabolite production from the paracetamol. So, paracetamol from NABQI, if you remember the NSAID, NABQI, that is a toxic metabolite that is more generated by the CYP2E1, and isoniazid, due to its induction of the CYP2E1, there is more chance of paracetamol toxicity in lower dose if patient is concomitantly taking INH. So resistance mechanism, mutation in the INHA or CAT-G or CAS-A, prevalence of resistance is 1 in 10 to the power 6 bacilli. So dose of the isoniazid is actually 5 mg per kg, but depending on the body weight, but maximum dose is 300 mg. Next important drug is rifampicin. This is also tuberculocidal, and this inhibits the growth of most gram-negative positive bacteria as well as many gram-negative bacteria like E. coli, Klebsiella, Proteus, Pseudomonas. So if you remember isoniazid, that is exclusively acting on the Mycobacterium tuberculosis, but rifampicin has many other targets. Rifampicin is active on many other cells, and it is very active against Staph aureus and coagulase negative Staphylococcus aureus also. It is highly active against Neisseria meningitidis, Haemophilus influenzae and Brucella, and it is also bactericidal against Mycobacterium leprae and other non-tubercular mycobacteria like the intracellular Scrophulosium, avium, etc. So mechanism of action, it enters the vessel in a concentration dependent manner and it inhibits the enzyme that is called DNA dependent RNA polymerase enzyme, and it is encoded by the RPOB gene to form a stable drug enzyme complex. So in short, it inhibits the DNA dependent RNA polymerase enzyme. So RNA synthesis is inhibited by the bacteria, and this is also having some sidal effect. So DNA binding drug binding suppresses the chain formation in the RNA synthesis. Pharmacokinetics, metabolism, one thing you have to remember that pharmacokinetics, food decreases the absorption of the rifampicin, that's why rifampicin should be taken on empty stomach. And it is potent metabolism inducer of other drugs. So INH is mainly a metabolism inhibitor, rifampicin is mainly a metabolism inducer. And concomitant use of different drugs which are metabolized by this cytochrome enzyme, their effect may be decreased. There can be good penetration of the penile tissue, but level in CNS is very poor, like 5%. And it is eliminated by feces, bile as well as urine, and you have to counsel the patient that it can cause your orange discoloration of the urine, and that is not a reason of discontinuation of the drug. Because of rifampicin, it is eliminated by some part is eliminated by urine, imparting them the orange color. And rifampicin for oral administration is available alone or as a fixed dose combination with isoniazid or with isoniazid pyrazinamide, and dose is 600 mg, but also depends on the body weight. Children should receive 10 to 20 mg per kg. And what are the other uses? So rifampicin, it is active on many other drugs and many other bacteria. Apart from tuberculosis, it is also active also used in leprosy, also used in prophylaxis of the meningococcal meningitis as well as 8 influenza meningitis, and is also useful in the brucella. And combined with beta-lactam and antibiotic of vancomycin, rifampicin can be useful for the therapy of the staphylococcus endocarditis or osteomyelitis. Adverse effect profile, hepatitis can occur. Rarely there can be hemolysis, hemoglobinuria, hematuria, flu-like syndrome of liver, fever, chills, myalgia. Rarely it can cause interstitial nephritis, eosinophilia, thrombocytopenia, hemolytic anemia. But always remember this orange stand discoloration on the skin, urine, feces, saliva, tears and contact lenses. The mechanism of resistance, once again, that is the alteration in the RPOB gene that causes resistance against the rifampicin, and incidence is 1 in 10 to the power 7 to 10 to the power 8 bacilli. So again, remember about the INH. INH resistance frequency is 1 in 10 to the power 6 and rifampicin is 1 in 10 to the power 7. So if we use INH and rifampicin together, then chance of developing resistance against INH and rifampicin both will be 1 in 10 to the power 13. That's one of the reasons why INH and rifampicin is given together to minimize the risk of resistance. Next tuberculocidal drug is pyrazinamide. Pyrazinamide is converted into the one active metabolite, that is pyrazinoic acid, by enzyme pyrazinamidase, and Mycobacterium tuberculosis possesses that enzyme. So Mycobacterium tuberculosis has pyrazinamidase, which deaminates pyrazinamide to pyrazinoic acid, and this is then transported to the extracellular milieu by an efflux pump. And in an acidic extracellular milieu, a fraction of POA, that is pyrazinic acid, is protonated to POAH that enters the bacillus again. And these are the proposed mechanism by which POAH exerts bactericidal activity. There is acidification of the internal milieu that inhibits the enzyme function. There is inhibition of the energy metabolism. There is inhibition of the ribosomal protein S1. There is result is toxic protein accumulation, and that also inhibits aspartate decarboxylase that inhibits the pantothenate and coenzyme A synthesis. So these are the proposed mechanism, but remember this acidification of the internal milieu, that is the mostly contributed to the pyrazinamide activity. Pharmacokinetics, nothing much to remember, and fast absorber, slow absorber, there are two varieties of patients, and fast absorber means there is rapid onset of action, that is pyrazinamide acts better in them. Therapeutic use, so co-administration of pyrazinamide has been able to reduce the duration of the tuberculosis therapy to 1/3. Previously tuberculosis therapy runs for almost 2 years, but pyrazinamide introduction has reduced the duration significantly to 6 months mostly, sometimes it requires 8 months. So there is almost 2/3 reduction in the TB relapse also. So there is 1/3 reduction in the duration of the antitubercular therapy as well as 2/3 reduction in the tuberculosis relapse case. And there is reduction of the length of therapy 3 to 6 months, producing the current short course chemotherapy. Dose requirement is high, so pyrazinamide is given mostly as a uncompleted tuberculosis in first 2 months only, and that is enough to reduce the duration of the tuberculosis treatment significantly. Dose is 1500 mg per day maximum dose, but depends on the body weight actually. Adverse effects, pyrazinamide has lots of adverse effects. It is the most common antitubercular drug to cause hepatitis, so there is significant elevation of the SGOT SGPT level, but unless SGOT SGPT level rises more than 3 times than the normal value, we should not discontinue pyrazinamide. Hyperuricemia is there because it reduces the uric acid excretion, and that there can be arthalgia also. It is not approved during pregnancy because of chance of this hepatitis. Okay. Mechanism of resistance, so pyrazinamide is with reduced affinity of pyrazinamide is the reason of resistance, because pyrazinamide is the enzyme which converts that pyrazinamide into this its active form pyrazinoic acid. Next first line drug ethambutol, and among the first line drug it is bacteriostatic. Mechanism of action, ethambutol inhibits the arabinosyl transferase 3, that is an enzyme, and this disturbs the transfer of arabinose into arabinogalactan biosynthesis, and result is it disturbs the assembly of the mycobacterial cell wall. So INH inhibits the macrolic acid synthesis, that is a part of the cell membrane. Ethambutol inhibits one part of the cell wall by inhibiting the arabinosyl transferase 3. Thus it disturbs the transfer of arabinose into arabinogalactan biosynthesis, that is an integral part of the mycobacterial cell wall. So arabinosyl transferase are encoded by EMB-AB gene. Pharmacokinetics, nothing much to remember. Therapeutic use, so isoniazid, it was used in tuberculosis exclusively. Rifampicin has many other uses, remember those uses. Ethambutol, pyrazinamide is once again exclusively used in tuberculosis, but ethambutol has some other uses, like it is active against disseminated MAC infection, that is the Mycobacterium avium complex infection, and also Mycobacterium cancers infection. And maximum dose is 1200 mg per day. Adverse effects, the adverse effect which we must know, that is optic neuritis, and it is manifested by impaired color blindness. That is manifested by color blindness. There is loss of ability to differentiate red from green. So there is, and also it results in decreased visual acuity. So decreased visual acuity and also red-green color blindness, optic neuritis. That is the commonest adverse effect of the pyrazinamide, and often children are less able to mention this effect. That means even if they cannot differentiate red-green colors, they are not able to report to their parents or doctors. That's why it is difficult, often it is delay in detecting the optic neuritis in the children. That's why in children below 6 years of age, normally pyrazinamide is contraindicated. And there is loss of ability to differentiate, also there is hyperuricemia due to decreased uric acid excretion. And these are the rare side effects, but remember the optic neuritis and the hyperuricemia. So hyperuricemia is adverse effect of both pyrazinamide as well as ethambutol. Next, aminoglycoside. Streptomycin is the first line, but rest amikacin, kanamycin are second line drug. Mechanism of action already discussed during aminoglycoside, that it inhibits the protein synthesis by binding to the 30th ribosomal subunit and cause misreading of the genetic code during translation. And it acts on the extracellular bacilli mainly, unlike the pyrazinamide which acts on the intracellular bacilli. And INH, if you remember, INH acts on both extracellular as well as intracellular bacilli. And there is resistance to streptomycin increasing, need to be given by IM route, that's why it is less popular now. Fluoroquinolone, Though minifloquinone was tried, but now we use mainly levofloxacin in MDR-TB or multidrug-resistant tuberculosis and moxifloxacin in the MDR or XDR-TB. And moxifloxacin is the furthest along with in clinical testing as an antituberculosis agent. It is being studied to replace either isoniazid or ethambutol. So moxifloxacin has been shown that if we introduce moxifloxacin in the tuberculosis regime, that can reduce the duration of therapy further. Bedaquiline, a newer drug that is origin is India. It acts by targeting subunit C of the ATP synthase enzyme that leads to inhibition of the proton pump activity of the ATP synthase. And in patients of drug-susceptible tuberculosis, rate of suprabacterial decline was similar to rifampicin and isoniazid. Approved in India recently for MDR and XDR-TB. So bedaquiline, it is often used in the resistant tuberculosis with good success. Delamanid is another new antitubercular drug. It works by blocking the synthesis of the mycolic acid. Okay. It is not available in India yet. So next few second line drugs, let's discuss in short. Ethionamide, it inhibits the mycolic acid synthesis. Structurally it is actually mechanism is almost same like isoniazid. It inhibits the activity of the ionase gene product and it does impair the mycolic acid synthesis. PAS, para-aminosalicylic acid, it is a structural analog of the para-aminobenzoic acid and this is substrate of the dihydroterate synthase, and thus PAS is thought to be a competitive inhibitor of the folate reductase. So if you remember the mechanism of action of the trimethoprim sulfamethoxazole, so PAS acts in a similar manner like trimethoprim. Cycloserine, that inhibits the alanine racemase which converts L-alanine to D-alanine. It impairs the cell wall synthesis once again. So if you remember the class of bacterial cell wall synthesis inhibitor, cycloserine was one of them. It inhibits the alanine racemase which converts L-alanine to D-alanine. Capreomycin, another drug, mechanism is almost same like aminoglycoside. Tedizidone, it's actually two molecules of cycloserine is tedizidone. Rifabutin, it is related to the rifampicin in structure and mechanism of action, but rifampicin has one property, that is drug metabolism inducer. Rifabutin is less potent in that. That's why rifabutin has less drug interaction than rifampicin, and it is less active than against the Mycobacterium tuberculosis, but it is more active against Mycobacterium avium complex, and it is weaker enzyme inducer. So it is used in treatment, especially in patients of HIV with tuberculosis, where we are using some anti-HIV drug like protease inhibitor, NNRTI, and if we use rifampicin, rifampicin induces this HIV drug, and often there is decreased activity due to enhanced metabolism. That's why if we use rifabutin, then there is less chance of this metabolism enhancing effect on the PI or NNRTI. Thus, anti-HIV drug retain their activity more in presence of rifabutin. That's why in TB HIV co-infection, if we need to give both types of drug, then rifampicin is switched to rifabutin. Otherwise, it is not used in tuberculosis. Okay, but it is used in MAC infection. So these are the drugs, first line and second line drugs we have discussed. But more important is treatment of the tuberculosis. So what is the treatment of tuberculosis? We have multiple goals. First goal is to kill the dividing bacilli. So bactericidal drugs are used to rapidly reduce the bacillary load of the patient, rendering him non-contagious and non-infectious, and so that sputum of the patient becomes negative. So initially, commonly pulmonary tuberculosis sputum is positive. So with good treatment, and if patient can follow the treatment well, can tolerate the medicines well, there is rapid sputum conversion from positive to negative, and that makes this patient non-contagious to the society. That is a huge boon to the society. The patient becomes non-contagious. Okay, so that's why initially our goal is to kill the dividing bacilli. Next, to kill the persisting bacilli. Even after we kill the dividing bacilli, if there is patient is non-contagious, that is sputum is negative, but we cannot stop the treatment. Then we can reduce the number of the drug. For initially we use 4 or 5 drugs, but later we can use 3 drugs to effect cure and prevent relapse. So second stage treatment is to prevent relapse and to ensure complete cure. And also our third goal is to prevent emergence of the resistance. Okay, so if we cannot use the drugs, cannot select the drugs appropriately, there is often development of resistance. So these are the three goals of treating tuberculosis. Now, why combination therapy? So H means isoniazid and R is rifampicin. H and R are most potent bactericidal. They are active against all population of the tuberculous bacilli, and Z pyrazinamide acts based on the intracellular bacilli and at inflamed site. Streptomycin is active only against rapidly multiplying extracellular bacilli. Ethambutol is bacteriostatic and main purpose is to prevent resistance. Combined use can shorten the therapy from 12 to 18 months to 6 to 9 months. Okay, so that is the advantage of using combination drug HRZE. Also, in sometimes we use S when there is intolerance to these first line drugs. So if we can use all them together, there is decreased chance of resistance, and also we can target extracellular as well as intracellular bacilli all more, and that ensures shortened therapy also from 12 to 18 months to 6 to 9 months. Next short note can come. What is DOTS? That is directly observed treatment short course, and it was recommended by WHO in 1995, and it is actually strategy to ensure cure by providing the most effective medicine and confirming that it is taken. So tuberculosis treatment, it is long, 6 to 9 months, and that's why compliance is often an issue, and often patients feel better after 1 or 2 months of therapy, and they tend to stop this treatment, and that's a huge risk to the society, because patients may become there is relapse, patient may can become infectious again, and that can spread to the other patients, other persons. So to ensure that the treatment is completed, directly of the therapy is advised, where first drug of the patient is given 1 week therapy, and first day drug is consumed in presence of health care worker, and rest of the tablet, rest of the week patient is asked to consume the tablets, and they are advised to come to the next week, and they have to return the empty tablet strips, so that it is ensured that patient has actually taken the drug, and then only they are issued dose of next week. Okay, so that is the directly observed therapy short course, and that is the strategy to ensure cure by providing the most effective medicine and confirming that it is taken. And consumption of medicine is checked by return of the empty combi packs when the patient comes to collect the medicine for the next week. So we have discussed that our first goal is to kill the dividing bacilli, make the patient non-contagious, and second goal is to make the patient completely cured and also prevent relapse. So to achieve the first goal, we are giving multiple drugs together, intensive phase, so where a health care worker watches as the patient swallows as the drug in her presence, and multiple drugs are given. And during continuation phase, patient is issued medicine for the 1 week in a multi-blister combi pack, and the first dose is swallowed under supervision. So intensive phase, at least 4 drugs are given, and it is directly observed, and in continuation phase, the patient is issued medicine for 1 week in a multi-blister combi pack, and number of drug is little bit less than the intensive phase, because main aim is to prevent the relapse. Short course chemotherapy, it was introduced in the 1972 by Wallace Fox and his colleagues from the British Medical Research Council. They showed that the addition of rifampicin and pyrazinamide to the regimes containing INH can reduce the duration of treatment significantly from previous 2 years to now 6 to 9 months. And all regimes have an initial intensive phase with 4 to 5 drugs for 2 to 3 months that rapidly kills the bacilli and makes the patient sputum negative, and that makes the patient non-contagious, and that is followed by continuation phase with 2 to 3 drugs lasting 4 to 5 months to prevent relapse. Okay. Next, there are category of the patient that need to be understood properly. So category actually depending on the status of the patient, what is the previous history of the infection, what is the patient's previous drug history, how long patient has consumed the drug before. Depending on this, few category of the patients is done so that we can select the drugs properly. So category 1 is new patients, sputum positive or sputum negative, pulmonary or extrapulmonary. So any new patient, that is category 1, sputum positive or negative, pulmonary or extrapulmonary. So remember, previously there was a category 3 where extrapulmonary or sputum negative cases were grouped, but nowadays all new patients, be it sputum positive or sputum negative, be it pulmonary or extrapulmonary, they are grouped under category 1. And category 2 is sputum positive previously treated tuberculosis patient. So category 2 is who have received treatment previously but not completed, or there can be relapse. So either can be there. This category 2 means either patient did not complete the course or took inadequate or irregular medications. They are called the defaulter, or relapse after getting cured. There can be relapse. This is the unfortunate case, or failed to respond. So treatment failure, treatment relapse, and defaulter. Treatment defaulter. These are the cases. Defaulter means who have not completed the course. Failure means who have not responded to treatment, and relapse means who have cured but once again there is relapse of the infection. So among these three patients, treatment is we call them category 2. And fourth edition of the WHO treatment of the tuberculosis guidelines published in 2010 abandoned reference to categories 1 to 4, and in patients who require tuberculosis treatment, the category 2 regime should be no longer be prescribed. So this is the newest edition. So tuberculosis treatment regime often changes, and nowadays, so previously category 1, category 2 treatment received, category 2 patients received different treatments, but now though the category is there, but treatment received by the category 1 and 2 are same. And whenever patient we are calling them category 2, always check for drug sensitivity test. This should be conducted to inform the choice of the treatment regime. So DST or the culture sensitivity test that is done when you are initiating treatment in the category 2 patient, so that we can know what is the resistance pattern, and accordingly we can actually modify or select the drug. Because we cannot, previously category 2 patients were given a fixed drug combination for 8 months without doing the culture test, but that is actually not scientific, because category 2 means there is a high risk of resistance development, and we have to check what is the drug resistance pattern of the patient so that we can select the drugs. Before this selection culture sensitivity report comes, we can continue the category 1 drugs, and when culture report is available, then we can switch over to the drugs which actually against which bacteria is still susceptible. Okay. Treatment of category 1, so 2 HRJD plus 4 HRE as per the 2016 Antitubercular guideline. Antitubercular is now changed to NTEP, National Tuberculosis Elimination Program. So what does 2 HRJD 4 HRE means? 2 HRJD means first 2 months intensive phase, isoniazid, rifampicin, pyrazinamide and ethambutol. Next 4 months continuation phase, Z, that pyrazinamide is omitted, we continue isoniazid, rifampicin, ethambutol. And daily treatment is advised. Often 5-weekly therapy is given where daily supervision is not possible, but in HIV patient always give daily therapy. Treatment of category 2, it is not followed now, 2 HRGDS plus 1 for HRGD5 HRE, because category 2 treatment is also nowadays it is also, they are also given category 1 treatment, and provide, and additionally their sample is sent for drug sensitivity test so that they can be started with the susceptible drugs rapidly without continuing these drugs for the 8 months. So major problem with the treatment category 2 regime was that streptomycin was being added to regime which a patient had previously been treated with. This goes against the principle of a never adding one single drug to a failing regime. So what does that mean? When the treatment regime fails, what is failure? Failure means, look at this next slide, failure means any patient of category 1 if has a positive smear at 5 months should be considered as failure. Okay. So even after giving 5 months of therapy, if patient's sputum is not still converted from positive to negative, then we call it treatment failure, and patient is categorized as category 2. And when this is treatment failure, we have to add at least 2 groups of drug. Previously what we are doing, only we are adding streptomycin, but that is against the principle. So nowadays it is confirmed that we have to add at least 2 new drugs to which patient has not been exposed before to adequately kill the tubercle bacilli. Okay, so treatment, that's why category 2 treatment is nowadays obsolete. Treatment failure means either sputum is not converted to negative after 5 months of therapy, or if sometimes even some sputum negative patients may convert to sputum positive, that is the reverse may occur. And sputum negative patient at any point of time if becomes sputum positive, that is also treatment failure. Okay, and then you have to add at least 2 groups of drug depending on the drug sensitivity result. So under the new daily drug regime, so that is this category 1 and 2. I have mentioned the category 3 is obsolete now. Category 3 was extrapulmonary tuberculosis or sputum-negative tuberculosis, that is also now grouped under category 1. Category 4 is multi-drug resistant tuberculosis, and category 5 is extensively drug resistant tuberculosis. I shall discuss one by one later. Now under the new daily drug regime, tuberculosis patient will be given fixed dose combination 3 or 4 drugs in specific dose in a single pill on a daily basis, and drugs will also be administered in a more scientific manner according to the patient's body weight. So fixed drug, so we have now we are giving this 2 HRJD as a single tablet and HRE as a single tablet depending on the phase of the patient. First 2 months we are giving this HRJD combination tablet, next 4 months we are giving HRE combination tablet, and in this tablet their dose is fixed. HRJD 75, 150, 400, 275. So H remains 75 milligram, R is 150 milligram, tyrosine is 400 milligram, and ethambutol is 275 milligram. Now how many tablets to consume? And depending on the patient's body weight, we have grouped them in 4 weight bands. 25 to 39 kg weight bands 1, and if patients come in body weight is between this 25 to 39 kg, we will receive 2 such tablets. So this combination tablet, 2 such will be consumed by the patient. If patient body weight is 40 to 54 kg, patient is grouped under weight band 2, then he will receive 3 such combination tablets. 55 to 69 kg means weight band 3, he will receive now 4 such tablets, and above 70 kg means he have to consume 5 such tablets. So combination is fixed. Number of tablets will depend on the patient's body weight, and in continuation phase also only just Z is omitted. HRE strength is same, 75, 150, 275, and depending on the body weight and weight band, patient is given 2, 3, 4 or 5 tablets daily, and as it is a combination tablet and it contains rifampicin, as rifampicin need to be given in empty stomach, this combination tablet is also given in empty stomach. Okay, and remember, if in body weight is changing during the therapy, but this weight band is kept fixed. Suppose patient's body weight is initially 53 kg, later it becomes 56 kg, but this weight band initially it was 3, 2, still it is 2. Okay, it is not changing to 3. And monoresistant tuberculosis, polydrug resistant tuberculosis, multidrug resistant tuberculosis. So monoresistance means any tuberculosis patient whose biological specimen is resistant to one first-line antitubercular drug, that is called monoresistant. So resistance to either H or R or Z or E or S, that is called monoresistance. Polydrug resistance means a tuberculosis patient whose biological specimen is resistant to more than one first-line antitubercular drug other than both H and R, that is polydrug resistance. And multidrug resistance means biological specimen resistant to both H and R. So any 2 drug resistance, that is polydrug resistance, but if these 2 drugs includes H and R, so H and R, both resistance to both, is actually multidrug resistant tuberculosis. And extensive resistant tuberculosis means apart from this H and R resistance, this is resistant to at least one fluoroquinolone like ofloxacin, levofloxacin or moxifloxacin, or one second-line injectable drug like caprimycin, kanamycin, etc. or amikacin. So these are the definition of polydrug resistant, multidrug resistant, and extensive drug resistance. So multidrug resistance means resistance to both H and R. Polydrug resistance means resistance to any 2 first-line drugs, may not be H and R. It can be H and E, H and Z, E and R, E and Z, etc. But if it is H and R, we call it them as multidrug resistant. And extensive drug resistant means apart from H and R, it is resistance to both also fluoroquinolone as well as aminoglycosides or second-line injectable drugs. So this how to treat them. This is under DOTS plus therapy. We shall discuss in the next class.